Hello, and welcome to this talk on managing difficult patient interactions. Thank you for joining me today on this relevant and topical subject. My name is Volker Hitzeroth, and I'm one of the doctors working at the Medical Protection Society in the South African team. And it's lovely to be here with you today. Just a brief disclaimer from my side. I mentioned that I'm a medical doctor, so I'm not a lawyer. I'm also going to make reference to 4 cases, and I would like to reassure you that they are true cases, but they have been changed somewhat and anonymized so as to protect everybody concerned. If you happen to recognize yourself in one of those cases, I assure you that it is not you, because we have made some changes so that people cannot be recognized. And lastly, just to remember that during this talk, I cannot give specific medico-legal advice today to you, but any member of the Medical Protection Society who wishes to receive specific medical-legal advice about a difficult or challenging scenario can email us on that email, which I've put on the slide for you. So, without further ado, let me start with the talk. And this talk is divided into 3 sections, and there you can see them. The first one is just some medico-legal facts. Then I want to speak about the causes of difficult interactions and the management of difficult interactions in the third part of the talk. Now, this slide will be shown throughout the talk so that you will be able to follow me and also monitor the progress of today's talk. Working at MPS, I'm obviously quite aware and alive to medico-legal problems. And maybe another way of wording today's lecture is not so much about the difficult patient interaction, but also, or maybe rather, who will actually complain about you and who will sue you. So let's have a look at the first case here, ladies and gentlemen. This is a true case that we are dealing with, and the patient wrote a letter of complaint to the HPCSA, and the words and phrases that the patient used in the letter of complaint to the HPCSA included the fact that they believed the doctor had a derogatory attitude and belittled me in front of certain family members. Now, this was in the letter of complaint and indicates that the patient was not happy. Now, of course, we don't know what happened during that consultation, and the doctor may not have had a derogatory attitude, and the doctor may not have belittled the patient in front of their family. But this, be it as it may, was the patient's perception of what happened, and hence the outcome of this clinical consultation was an HPCSA complaint, a threat to institute a summons and sue the doctor for alleged negligence, and then also, interestingly, the patient reported the doctor to the medical aid, requesting a billing audit of the doctor's practice, and threatened to report the doctor to the South African Revenue Service for an audit as well. Another little medico-legal tidbit here is that the New England Journal of Medicine some years ago published an article and this interesting table showing the proportion of physicians facing a malpractice claim annually according to their specialty. And you can see that according to the New England Journal of Medicine, the neurosurgical specialty is right at the top, followed by a number of other surgical specialties in the top half of this graph. Interestingly, the non-surgical specialties, the consulting specialties, are mostly in the second lower half of this graph. Now, from our side here at the MPS, we see a slightly different picture in that neurosurgeons are near the top, but also near the top, I would suggest, are our obstetricians in South Africa and the pediatric neonatologists. Now, you can see in this graph, the pediatric specialty is second from the bottom. And my experience would be that pediatrics, and specifically the neonatology part of pediatrics, is nearer the top. And then, of course, in general, the consulting specialties are nearer the bottom. The next slide shows another graph from the same article and indicates the cumulative career probability of facing a malpractice claim or indemnity payment according to the risk of specialty and the age of the physician. And in summary, you can see that the left-hand vertical axis shows the probability of the first claim against the practitioner, or then the indemnity payout, whilst the horizontal axis shows the practitioner's age. And maybe just to give you the brief overview, the top curved line is maybe the most interesting, which seems to suggest that the practitioners in the high risk specialties, so maybe here see the surgical specialties and pediatrics and neonatology specifically, would usually receive a claim in alleged negligence quite early on in their career, the first claim, or for that matter, a later payout of indemnity money, would be quite early on in their career compared to the lower risk specialties. So let's have a look at some more medico-legal facts here. A number of studies have shown that of all hospital admissions, 10% involve an adverse outcome. Half of these adverse outcomes seem to be preventable, and only 5% of patients who suffered an adverse outcome took medico-legal action. Now that's an interesting statistic. Furthermore, studies have found that many medico-legal claims do not involve error, or a medical error, a medical mistake, or for that matter, negligence, clinical negligence. So many medico-legal claims and actions and consequences do not involve a medico-legal error, a clinical error, or clinical negligence. There was no error found in 37% of medico-legal actions. Now that's an incredible number. That means more than a third of medico-legal actions actually had no clinical error on the part of the practitioner. Interestingly, again, no injuries were found in 3% of actions. And that's a bit odd, because you would assume that if a patient institutes a claim in medico-legal negligence, there must be some sort of harm or injury. But it could be that this 3% of actions is instituted because of other reasons other than harm or injury. Our own data here at the Medical Protection Society seems to suggest that many, indeed more than 50% of our claims are successfully defended or have been withdrawn by the plaintiff, which would suggest again that more than 50% of claims seem to be unfounded. And you can see here that from 2015 all the way through to 2020, more than 50% of the claims that we've had to deal with have been successfully defended or gone away, except for 1 year, which was 2017, which seems to have been a slightly bad year for us. So, ladies and gentlemen, you're going to be wondering what this is all about. And where I am heading with this to get to a difficult patient interaction is the following few slides. It seems as if the medico-legal risk does not necessarily correlate with your clinical competence. There are other things that seem to be driving medico-legal risk as well. And here we have some of them. There are a number of factors in the decision to take medico-legal action against you. So what this means is patients weigh up numerous other factors before or in order to decide whether they take medico-legal action against you. And here they are listed. There are usually a number of predisposing factors that have occurred or that the patient has perceived to have occurred. And one of those is rudeness, alleged rudeness on behalf of the practitioner, or delays, inattention, a practitioner who shows no empathy or who is arrogant, who is apathetic, and who does not communicate or miscommunicates. These are a number of predisposing factors that lead into a patient deciding to take medico-legal action against you, such as a complaint at the HPCSA. And you can see where this is going to link up with a difficult patient interaction. The second group of factors are the precipitating factors, and that is maybe an adverse outcome, an injury, an iatrogenic injury, incorrect care, or other system errors or mistakes. So what this slide would suggest is that there often are a number of predisposing factors that might just make the patient decide to take further action against you. Whilst if those predisposing factors were not present, possibly the patient might not necessarily take the medico-legal action against you. So what am I saying, ladies and gentlemen? I'm suggesting that poor communication and low patient satisfaction are linked to patient complaints and medico-legal action against you. If we put this another way, then patients seem to be reluctant to sue or complain about doctors that they actually like. Now that's an interesting thought. So it is important for all of us to realize that patients assess our clinical competence based on our interpersonal skills and our interactions with them during the clinical consultation. Patients tend to trust doctors who they see as being caring and competent. And that in a way makes sense, because patients would struggle to judge our clinical competence, but they are very good at judging our interpersonal skills and our interactions with them. So here's another case, another true case. In the letter of complaint to the HPCSA, the patient wrote the following, referring to the doctor. He was running very late and then said, "I cannot be rushed and you can just rebook." The patient also said the doctor was incredibly unprofessional, very rude, unkind, and insensitive. And lastly, the patient said that the doctor was disrespectful of my time and my work. And here it's probably worth remembering that patients also give up of their time and their employment time and their income possibly to come and see us in our practice. And of course, if there are some of those predisposing factors, then patients can be angry and dissatisfied. And in this case, this patient sent a complaint to the HPCSA and made a threat to place a post on social media. So much of what I've said does relate to a difficult patient interaction. And all of us, independent of whether we are general practitioners or various specialists, occasionally have to face a difficult interaction and have to manage it successfully so that we do not have an adverse medico-legal outcome, and of course, not an adverse clinical outcome. So let's have a look at some of the causes of difficult patient interactions. And the academic literature has numerous good articles on this. And if I was to summarize the findings in general, I would say that there are 4 separate factors that determine whether an interaction with a patient can be or is going to be difficult. And here I've listed them for you. There are a number of patient-related factors, there are disease-related factors, there are system-related factors, and of course there are doctor-related factors that are all about you, your style, your knowledge, and your bedside manner and clinical interaction with a patient on the day of the consultation, or maybe in follow-up arrangements with phone calls. So a difficult interaction tends to be caused by a number of factors or processes. Let's look at these in detail, and you will recall or remember much of what I've said from difficult patient interactions that you might have had. Have a think back of some of your patient interactions that you would define as being difficult. And let's place some of these factors that cause the difficulty into that clinical context of yours. If we look at patient factors, there are three that I could distill from the literature. And the first one is patients and their supposedly unrealistic expectations. The second patient factor is what we would call a discordance between the disease and the illness, and I will elaborate on that on one of my next slides. And finally, if there is rigidity on the patient or your behalf regarding the various alternatives and options available to a patient. So let's interrogate these in a bit more detail. Unrealistic expectations. Well, we've all faced them in our clinical scenarios, in our clinical consultations. You would have had many of these, and I had them when I was a clinician practicing. Patients have preferences and expectations about all aspects of healthcare. Of course they do. They Google, they hear it from friends, they hear it from their best mates, and of course, they hear it from everybody else in the media. And that has maybe been especially so in the last 18 to 24 months. Unmet expectations often lead to patient disappointment. And when patients are disappointed, it is easy to blame the other, or for that matter, to blame you, rather than share the disappointment. So the management of unrealistic patient expectations is very important to reduce the chance of a clinical consultation ending up being difficult. So how do we do that? And here are some hints. Identify patient expectations early on, during the first half of the clinical consultation. Listen to the patient for a good long time and hear what they have to say. And then ask them, what would they like to have achieved during this consultation? What are they expecting you to do? Flush out their expectations early on so that you know where you stand and what your options are. And if there are unrealistic patient expectations, then address these calmly, patiently, and professionally. Don't ride roughshod over them, don't negate them, but deal with them professionally as any good doctor would. Remembering that unmet patient expectations can lead to disappointment, complaints, and medico-legal actions, as my two previous cases have demonstrated. Another patient factor is the discordance between disease and illness. And here it's worth pointing out maybe that discordance makes us uncomfortable. And discordance often occurs when there are different interpretations of various facts. Disease is what you and I have studied for many years and what you and I see in our clinical consultations. It's all about pathology, physiology, it's about signs and symptoms, it's about treatment options, and so forth, pharmacology, surgery. That's the talk that you and I do. That's what we're good at, and that's what we've studied so long for. That's what we're the experts on. But illness is the patient's experience of that disease. And every patient experiences their disease differently. They have different thoughts, they have different feelings, they have different fears, and of course, they have different expectations. And if there is a big discordance between the disease, that's us on the medical side, and the illness, which is the patient side, then there are possibilities that this could become a difficult patient interaction. Similarly, if there is what I call a band of comfort that seems to be quite rigid, then there is a chance that the consultation will deteriorate into increasing difficulties. If there is rigidity regarding the various alternatives, the options, the treatment choices, then you may not find common ground with your patient, and there remains this gap, this space where you two are not meeting. You and the patient are not meeting each other in the center ground, and that can cause difficulty for you, for the patient, and of course, ultimately, adverse medico-legal outcomes. The second large group of factors that contribute to a difficult patient interaction are disease related. And here I've just listed some of them, and you might even recall from your studies some of the disease factors. We know that patients who have multiple various complaints at the same time occasionally are difficult to manage. Patients presenting with chronic pain or those presenting with alcohol and drug addiction often also are difficult situations to manage. And finally, mental illness, and especially the personality disorders, are occasionally patients who are difficult to manage. And the literature seems quite clear that personality disorders seem to feature quite prominently in the studies relating to difficult patient interactions. And I'm sure you have a few other conditions, diseases that you feel contribute to difficult patient interactions. The third group of factors or causes that contribute to difficult patient interactions are system factors. Those are beyond you and your patient, and they relate to the system that we work in, that we live in, and the society that we function in. And here we have time pressures, how your diary looks, what your personal life looks like, and how you interact with time between your work and your private life, how full your secretary books your practice, whether or not you allow or permit interruptions by phone calls, consultations, or for that matter, staff members, whether or not your consultations are private, or whether there's noise in the background. Cultural differences, of course, are equally important. Limited resources, we've seen much of that in the last 24 months, not just in South Africa, but across the world. When you do not have the resources that you want or that you need, knowing what you want and need to provide good patient care, then things get difficult. People get impatient, expectations are not met, and you might end up with a difficult patient interaction. And of course, there could be endless third-party pressures from family members, from insurance companies, from the medical aides, very prominent in South Africa, who seem to pressurize practitioners and, for that matter, also patients down certain treatment alleys. All of these system factors cause and contribute to potentially difficult patient interactions. And finally, the last group of factors relate to you and me, to us, to the doctors, to ourselves. And that is our own personality. We all have our own little quirks and foibles. We all have personality traits, although I would hope that we are not particularly personality disordered. But be that as it may, our own style of thinking, acting, and interacting contributes to patient interactions and occasionally might contribute to a difficult patient interaction. If you've had a previous encounter with similar people, maybe you've seen numerous drug and alcohol-related patients, or for that matter, patients with chronic pain, and you've had previously negative encounters. Maybe those patients, or one or two of them in any event, complained about you at the HPCSA, and now you find you are unsure, anxious, and worried about dealing with patients with chronic pain or drug and alcohol-related problems. The degree of training and how much you have skills to handle difficult situations. What were you taught in your undergraduate training about how to deal with difficult situations and difficult people? Maybe in your specialist training, you received some training about how to manage such scenarios. Now, sadly, I suspect none of us had enough of such training, but I recall from my undergraduate training that I did have a lecture or two on how to deal with difficult people and difficult scenarios. We all carry our own emotional baggage. We all have our own psychological twists, and hence that could contribute to a difficult patient interaction. We all have certain views. We all have our own mental health concerns. And lastly, what we call the susceptibility to HALT stress. Now, you might be asking, what does HALT stand for? And of course, that stands for hungry, angry, late, and tired. And again, the South African healthcare profession has a lot of that, where our practitioners are tired, they are overburdened, overworked, and exhausted. And all of that will reflect in your patient interactions, your consultations, and potentially lead or contribute to a difficult patient interaction. So, how can such difficult encounters make us feel? How do you feel? What do you feel like after or before you've had a difficult patient interaction? Maybe you can see a particular patient in your diary later in the day. How do you feel about it when you know that that might be a difficult patient interaction? And what do you feel like after you've seen such a patient? And here's a list. In general, the literature suggests that healthcare practitioners feel frustrated, resentful, fearful, or even deprofessionalized with system factors, angry helplessness, hopelessness, and powerlessness when you are working in a bigger system where you have very little say and you know that your clinical autonomy is frustrated on every move and every turn. And then a patient is in your consultation who has an unrealistic expectation and you're still running late, not having had lunch. All of that leads to a difficult patient interaction and makes us feel frustrated, resentful, and possibly angry, hopeless, and powerless. So that perception of difficulty, that feeling, that emotion that you and I feel in those instances also affects our further behavior. So things could become a vicious cycle, a circle and a merry-go-round where things just reinforce difficulty and challenges. So how do you greet such patients? Our perception of difficulty affects the way we greet these patients. Our non-verbal body language also expresses how we feel, and we need to be aware of that. When you see such a patient, when you see them in the waiting room, when they walk into your office, what is your demeanor like? What is your facial expression like? What is your body language like? Such perceptions also pollinate the degree to which we listen to our patients. Do we switch off early knowing that this will be difficult and you cannot resolve the problem? You cannot address the multiple complaints and you cannot relieve the pain. Do you stop listening to your patient at that point? Do you just wish that the time would tick over so that you could move on and go home? All of that is sensed by our patients. The information we provide, of course, is also determined by our own views, thoughts, fears, and perceptions of such scenarios. And whether or not you involve the patient ultimately in the joint decision-making, as you should, will also be determined by how you feel about these encounters. And of course, all of that will potentially lead to a difficult interaction and a possible complaint or medico-legal challenge later on. So here's another case, ladies and gentlemen. It's a true case. And the patient, in their letter of complaint, wrote that the doctor, she was very rude to my mum. She carried out the assessment in a very arrogant manner, as if she was doing me a favor. She came in late, coughing and blowing her nose. Now, during the time of COVID, that would have been a worry for the patient. The doctor did not seem interested in my symptoms, and she obviously thought that my illness was not serious. And this patient sent a complaint to the HPCSA about this practitioner's conduct. And unfortunately, the practitioner is now embroiled in a lengthy, complicated, and uncertain HPCSA complaint. And you will notice that none of this has to do with the clinical acumen of the practitioner. It all has to do with bedside manner and patient interaction. So, ladies and gentlemen, what can you do about such potentially difficult patient interactions? And I've looked at the literature, and I'm going to show you two articles that I've come across. They're available on the internet. I can't vouch that they are truly brilliant articles or not, but I thought they each provide a good overview and an easy to digest narrative that would help the average practicing healthcare practitioner in South Africa. So the first article is this one. It's a very recent article you will see in July 2021, published in Current Psychiatry. It's about managing difficult patient encounters, and it's written by Professor Black, who happens to be a psychiatrist. There's much of this sort of literature in the mental health and psychiatry literature. And Professor Black highlights the 3 types of contributing factors: the patient, the doctor, and the system. Now, that is similar to what I've mentioned earlier. I've also added in the disease or the illness for that matter. But this is a very good overview article that all of you can access from the internet, and it makes interesting reading. The second article that I came across is somewhat older, but it is this one in the American Journal of Medicine from March 2015. And it is about what mediators can teach physicians about managing difficult patients. And when I read this, it's only about 3 or so pages, so it's not a particularly long article, and it's easy to read. It highlights 7 skills that mediators use during difficult mediation processes that they believe doctors could also use when they manage difficult patient interaction. So an easy to read and easy to understand article with some useful and helpful hints that I think would help every practitioner when they deal with a difficult patient interaction. Other than those 2 articles, I thought I would just share some practical advice. Much academic research on the practicalities of difficult patient interactions is out there, but here's a brief list of some practical advice, and you will hopefully recall some of this from your training. But it is thought that regular short visits on a predictable, usual, standard day and time would help such patients rather than having many unscheduled and urgent visits at short notice that are pushed into a very busy day already. So routine and repetition and regular contact with such patients will probably ease your burden and assist the patient. It's also worth remembering that you might want to consult such patients at the end of your busy day, in case there is some overrun, so that you're not pushed for more time and other patients are now impacted and run late too. So plan it for the end of your day so that you have enough time to manage whatever the patient brings to your consultation room. Remember, you're not alone, although it might feel that way, but there are many doctors who will have a lot of sympathy with you in your situation, because every one of us has had to manage and help difficult patient interactions. So request an occasional second opinion, and I'm sure many of your colleagues, either in the practice or down the road, would hopefully be happy to give you a quick second opinion. Consider specialist referrals as needed, but of course you don't want to over or under refer to specialists. So it is a bit of a difficult decision-making process, but sometimes specialist referrals do help, just to either confirm that you're doing everything right and you've not missed anything, or to point out a further option and avenue that you could explore. Remember to do regular and detailed physical examinations and document those in your notes. They are reassuring to the patient and they help you ensure that you're not missing anything. Do targeted special investigations. Of course, again, you don't want to over or under investigate, so you need to choose your special investigations cautiously and with clinical appropriate core motivations. Get collateral information, very helpful to speak to a family member, to speak to the patient's spouse, with patient permission, of course. Might confirm much of the information you have already, and hence your level of worry and anxiety and uncertainty can be reduced, and you might feel reassured. Of course, collateral information might also provide you, again, with further helpful new information that you might have missed. Ensure that you have peer support, because managing difficult patient interactions can be challenging and very draining. So speak to your peer in confidence. Share your burden with a colleague in confidence. Ask advice or just time to share your concerns. The ultimate big worry, of course, in such patient presentations is that there is a real risk of missing a serious condition. Because you're so used to this patient having multiple complaints that are unfounded, you might miss a serious condition. And here I just want to point out that we should all beware of the known imitators, the known high-risk conditions, various cancers, paraneoplastic syndromes, autoimmune diseases, various infections, tuberculosis, syphilis. All these conditions can present in multiple, complicated and complex ways, and you wouldn't want to miss any of those. So have a high index of suspicion for true and genuine illness, but manage the patient appropriately. And of course, the literature is full of much more helpful and practical advice. And if you happen to have a handful of such difficult patient interactions, it might be worthwhile to recap some of the literature or your undergraduate notes. So, ladies and gentlemen, practically, what can you do? This is an important slide, and I would like you to focus on it and just imbibe this slide and the 5 bullet points that I've listed here. The best thing you can do with difficult patient interactions so as to help the patient, help yourself, and prevent a medico-legal complication later on is this list of 5. Connect with your patient. So it's about that doctor-patient relationship. Listen to them. Give them a minute at the beginning of the consultation just to share their concerns and fears without interrupting. Empathize with their experience, and then gently ask for more information. Ask them to elaborate. Ask them to expand on their fears and their experiences and their expectations. And then towards the end of your consultation, review everything and check that you've got it right. Ask them to confirm. Ask them to check that what you're saying and thinking is correct. Can they confirm that their concerns are whatever they might be? And can they also confirm that they are happy to proceed with the following treatment plan? And then listen to what they say. Ask open questions and give them an opportunity to respond. So overall, ladies and gentlemen, you can choose how to respond to difficult patients and difficult patient interactions. You can choose which way you want to manage such consultations. And that, of course, immediately brings the next question, ladies and gentlemen, which is, so what is an effective response when you are dealing with a difficult patient interaction? And here we go, ladies and gentlemen, a conscious, skillful action in the best interests of the patient would be the best response. And this is now an important part here. It may require you to diagnose and manage the actual interactional difficulty before you get to the clinical diagnosis and the management of the disease. So you might have to diagnose and manage the difficult interaction before you actually get to manage and treat the disease. Now that might be somewhat challenging, but let's have a look. A number of effective skills and strategies are available to us. And maybe the first one here is you need to recognize in your own mind that there is an interactional difficulty. Now that might seem obvious, but some practitioners seem to struggle with this too, seeing the number of complaints we have about this. So in your mind, recognize during the consultation that this could potentially be an interactional difficulty. This could possibly now turn into a difficult patient interaction. And then you might choose to diagnose that interactional difficulty more formally, and we will give you some example on some of the next slides. Throughout this process, please continue to support the patient. Remember, this is not confrontational. It is about supporting the patient and guiding them into good clinical care. Acknowledge the problem to the patient, and occasionally, if needed, and if there are unrealistic expectations, state your boundaries clearly, but calmly and professionally. So how do you recognize this interactional difficulty? And sometimes it's easy and sometimes it's not. But take note of the verbal and non-verbal mismatch from the patient. What are they saying and how are they acting? Or how are they acting and what are they then subsequently saying? Is the patient interrupting you? Are they repeating something that they believe you have not heard? Or are they just shutting down and being quiet because they disagree with everything you've said? Are you aware of these sort of cues during your consultation, and you should be. Unexpected patient resistance or opposition to what you said might be a signal that there is an interactional difficulty. Or when you find yourself disengaging from the patient, when in your mind and in your thoughts you've already moved on and you're having some maybe particularly negative thoughts about the patient and the interaction, stop yourself, recognize where you are, and then recognize your own negative thoughts and emotions, as I've mentioned. And then comes the diagnosis, the process of diagnosing the interactional difficulty. Think to yourself, what is the difficulty? Where does it lie? What does the patient think about all this? Are you actually on the same page with the patient here? And then how can I approach and deal with this interactional difficulty? Throughout this process, I mentioned, continue to support the patient by active listening. Demonstrate an interest in the patient's reality in whichever space they're in and whatever they fear and worry and expect. Demonstrate an interest. It doesn't mean you have to agree, just demonstrate an interest by active listening. And occasionally clarify the difficulty by asking some respectful questions to demonstrate a deeper understanding of the patient. Again, it doesn't mean you have to agree with the patient. You are just trying to clarify what they are thinking and what they are wanting and what they're expecting. Just merely asking gentle, probing, open questions will deepen the patient's thoughts, feelings towards you. They might even start liking you and hopefully not complain about you. Show empathy. The patient must be heard and understood, no matter what space they're in, no matter what thoughts they're having, and no matter how much they disagree with you. And then, like I said, review, summarize, and reflect back. Check whether you have understood correctly, and then integrate everything into the patient's agenda, your own thoughts, your own plans, and your own treatment approach. Try and integrate that into the patient's agenda. Might be difficult occasionally, but the more you do it, the easier it will become. And then you could acknowledge the problem to the patient. And I'm going to show you some examples just now. So you might want to verbalize your diagnosis of the difficulty, of the interactional difficulty to the patient. You might even seek their agreement. They might also feel something like an interactional difficulty. They might agree with you. You might even be on the same page when it comes to the diagnosis of this difficulty. And then by agreeing on the nature of the difficulty, you may be able to facilitate the solution and move forward and progress the patient's care. So on the next slide, I've got some examples for you. There we go. Some examples of how you could approach this process. You could say the patient's name. So in this case, let's use John. John, you seem to be asking me for guarantees, and I cannot give you any. That's making things quite difficult between us, isn't it? You can see there's no confrontation there. There's just a kind, courteous, professional discussion. Or Mrs. Setti, it seems to me that while I'm very concerned about your condition, you believe that it is not serious. That's causing us some frustration. Is that right? Can you see how the interactional difficulty has been mentioned and highlighted and pointed out in a very kind and caring manner? There's no confrontation. There's no disagreement. There's just a sharing of concerns. Sometimes patients have unrealistic expectations, as I mentioned, and then you can state the boundaries, because breaching such boundaries can lead to feeling trapped for the doctor, cynicism, shaken self-respect, anger, and medico-legal consequences, and that's what we see. Doctors are often asked to do certain things, to prescribe certain medications, or to follow a certain treatment approach that the doctor might disagree with, but the patients are insistent, so they are pushing your boundaries. And from our side, we often see that such problems, when they occur, result in unethical, illegal, or immoral conduct, or at the HPCSA, unprofessional conduct. So clearly state your boundaries calmly, factually, and respectfully, not confrontationally and in anger. Be flexible with different patients in their different clinical contexts, of course. Tailor-make your approach to each patient and their problem. And always explain your reason for upholding the boundary in terms of the patient's best interest. Now, that might sound contradictory, but I'm going to show you examples on the next slide, how you could tailor your explanation and your reason for maintaining your clinical boundaries in terms of the patient's best interest. So let's have a look at two more examples here. Another two examples. Mrs. Jindal, I want to make sure that we get the best possible result for you and that nothing we do jeopardizes your future prospects. Can you see how this is termed in terms of the patient's best interest, the best possible result for you, and that nothing we do jeopardizes your future prospects or your future health? Second example, something like, because of that, I won't be able to go along with your request for me to provide you with that medication. So in order to provide you with the best possible care, I won't be able to go along with your request for me to provide you with that extra medication or that higher dose or that longer prescription or giving you a prescription without seeing you in my consultation room and checking that you are still healthy and all is well. So again, there's no anger, there's no confrontation. They are just kind words and a suggestion that you would like to provide the best possible care to the patient. So, be solution focused. Focus on good clinical care, and then slowly move your consultation towards a mutually agreed way forward, which is often more effective than debating points of disagreement and getting into an argument and digging your position in, while the patient will then subsequently dig in their position. Assist the patient to identify and generate various solutions, and that would encourage ownership and implementation. Ultimately, it would encourage compliance with the agreed treatment plan. Patients may require significant encouragement and support to generate solutions, because we've all had patients sitting in front of us who just cannot generate any options. And then it all falls back down to you. The clinician, that is you, while you are free to offer suggestions, you should avoid taking over the process of problem solving. It's not for you to necessarily come up with all the options and solutions. It is just for you to come up with the clinically relevant and good solutions and place those on the table. And if need be, gently and kindly repeat them and explain that they would be the best solutions or the best options or the best treatment in your view, as you would only want the best care for your patient. And I've mentioned already, try to avoid arguments. Stay solution focused. Keep that patient relationship going and try not to prove that you are right and they are wrong. Avoid the but and the why and the with respect comments. Try and engage the patient and draw them into your treatment plan by pointing out what we've mentioned earlier. And when you ask your review questions, your summarizing questions, do so in a manner that the patient can agree with, so that you both come forth at the end of the consultation having agreed on a treatment plan that both of you feel is in the patient's best interest. And finally, respond to the emotional content rather than any irrelevant, incorrect, or exaggerated words. Patients, and unfortunately doctors too, occasionally say things that might be inappropriate, that might come out in anger. Try not to do that. Try to leave out the arguments, the anger, and the irrelevant, incorrect, or exaggerated words, and rather deal with the problem at hand. And I'm coming to the end of my particular talk today, and I want to finish with another case. The last slide for today is another true case. And here the patient wrote in the letter of complaint to the HPCSA. The doctor became condescending, judgmental, and hardly paid any attention to what we were saying. The doctor accused me of a certain thing. They used a confrontational tone, and he banged his fist on the table. He aggressively stated that he wanted a yes or no answer. He cut us off, shouted, and was so irate. Now again, we don't know what happened in the consultation, but this is what the patient experienced at the time. Now, I would hope that this is exaggerated, but we don't know. As I said, we were not there. But be that as it may, this is the complaint that was lodged at the HPCSA. And again, I would like to point out, it's not about your clinical acumen. This is not having made a diagnosis incorrectly or a wrong treatment plan or some side effect that they weren't informed about. This is about bedside manner. This is about your interaction during the clinical consultation. And unfortunately, this resulted in 2 complaints, an HPCSA complaint and a complaint at the hospital. So, ladies and gentlemen, having now come to the end of my talk, I will open the floor to questions, and I will certainly be available for that. I thank you for your time, and thank you for spending the last 45 to 50 minutes with me here today. Thank you and goodbye.